In our world of oncology today, one of our biggest problems is we don't know who to give adjuvant therapy to and who not to give adjuvant therapy to. We don't know who's going to have their cancer come back and who's not going to have their cancer come back. And so we've needed tools that will enable us to predict that better. And circulating tumor DNA in this minimal residual disease setting is proving to be a very useful tool to distinguish those that are destined to have their cancer come back and those that maybe will not. And so as this gets increasingly incorporated into our daily practice, I think we will refine our treatments, our adjuvant therapies. We will improve and smooth out and simplify our long-term follow-up for patients. So this kind of technology is potentially transformative to our entire practice in early-stage colon cancer. We all recognize that there are a lot of people in this space that are trying to develop assays for minimal residual disease, and Signatera is clearly one of the leading products that is out there. They come from a base of other medical fields that has now entered into the world of oncology, and the data that they have begun to accumulate in the clinical trials that they are doing prospectively, I think are really going to be standard setting in the space of circulating tumor DNA and minimal residual disease. We are in an unprecedented time for all of us, and in nowhere is this more true than in the world of oncology, because at least for us, cancer care is not elective. You can't just put all of cancer care on hold for the next couple of months and we'll come back to it later. We have to keep it going. So we have to have decision making for patients in real time right now. Our patients who had surgery for, say, colon cancer a month ago, well, they need to know whether or not they need adjuvant chemotherapy. Or alternatively, our patients who are in long-term follow-up or who need to be followed, do they come in and get a CAT scan or not? Are they supposed to come in and get blood tests when we're trying to keep people out of our hospitals to decrease risk and decrease infection? So assays such as the Signatera assay enable us to get more information on patients. And what's particularly interesting, and I just learned about this access program only recently, is that if you want this for your patients, they'll actually go to your patient's house and obtain the sample for them, so that the patient doesn't have really any major exposure to a healthcare environment for this. So having just heard about it, having everything changing day by day, week by week, this is the sort of assay that I think is a legitimate thing to be doing in our patients today. Now, how you would apply this is a little bit more controversial. If you got back a result of no circulating tumor DNA, well, that's reassuring. It's not 100% correct, but it's reassuring that that patient maybe could wait on adjuvant therapy or maybe not take it at all. On the flip side, if the patient has a positive assay, this is a patient who almost inevitably is going to have recurrent cancer based on all the evidence that we have to date. So I think that's a patient where the risk of coming in to get some treatment or maybe just oral chemotherapy is worth taking, even in the time of the COVID-19 crisis. Our group recently had a patient, stage 3 colon cancer. The patient was in his 60s and had some positive lymph nodes. And so we were all thinking about, okay, what do we do? The surgery happened just before the sort of lockdown. The patient is anxious, recovered, eager to get going with any treatment that might be offered. And so we said, well, how urgent do we need to bring this patient in? Should we give the patient oxaliplatin? Could we use just capecitabine and do that remotely? And so one of the things we decided to do was to obtain a circulating DNA test. The result is not back yet, but we are going to incorporate that into the decision making. We're also recognizing that you do want to get started within about 4 to 8 weeks. So maybe we can drag our feet a little bit. Maybe we could start some capecitabine and decide about the oxaliplatin depending on the positive or negative of the circulating tumor DNA test. So active case going on right now at our shop here at Georgetown.